Hey everyone, welcome to the main event. It is Monday, June 26, 2023. Thank you so much for joining us today. Got a great show lined up, I believe, because we got a great guest today, and I'll be getting into that here in just a little bit. But if you just now found this channel, don't know who I am, what I'm doing behind this microphone, my name is Joe Tillman, sometimes known as the original hair transplant mentor, meaning I was the first guy really on the planet to start live blogging, or not live blogging, but documenting in near real time what it's like to go through a hair transplant. This is way back in the early 2000s. It was 2002, and I was literally updating with photos because video was too hard back then. Every week, multiple times. Hey, here I am after my surgery, even during my surgery. Here are my grafts being cut. Here I am after surgery on my boat, or hiking or whatever. And that kind of led me into the industry because I was so passionate about it. And it started because I was a repair patient, having had 2 bad hair transplants 9 years before. This is in 1990s, when our guest was maybe in elementary school. I don't know, because I'm older than him, and I tease him about that, but I can because he's a good guy, and we get along great. But moving back to this channel, so for the past 8 years, been working independently with now 15 different doctors worldwide, and it's because I think they're worth considering. I actually do a review of them. I actually run them through the mill. It's not just looking at pretty pictures on the websites and saying, yeah, I want them on board. I get contacted, we talk about it, I review their information. I actually talk about what they do in the surgery room, how they take care of patients, like the whole 9 yards. And then I might accept them. And the next person you're going to see on the screen right next to me, he was one of those people. And I'm going to bring him up real quick. We got Dr. Aron Nusbaum in the house. Thank you, Dr. Nusbaum, for joining us. How are you today?
Wonderful and thrilled, excited to be here yet again.
Yeah, yet again, exactly. Because the first time we had some technical difficulties, and I did try to salvage that after the fact. I tried to edit the audio, but it was just too bad. So we're trying it again. We're doing a version 2.0. I appreciate you joining us. How are things down in South Florida right now?
Rainy summers in South Florida, but people's hair is growing, so life is good.
Life is good. And I would like to publicly congratulate you on your new status of fatherhood. Just, was it 3.5 weeks ago?
3.5 weeks. We have a 3rd-generation hair transplant doctor in the making. So
I wouldn't doubt it. I wouldn't doubt it. Just getting the same start that you did so many years ago. So congratulations. I'm very happy for you. And for your wife, of course. So I guess, just to let everyone know or remind everyone, this is a call-in talk show, so the line is open, and you have an opportunity to speak with Dr. Aron Nusbaum of Miami Hair in Miami, Florida. Toll-free number, 1-833-563-4247. This is a rare opportunity to speak with a hair transplant mentor accepted member, this being Dr. Aron Nusbaum. Before we take any phone calls, Doc, what's new at Miami Hair? What's new? What's changed? What's going on?
Well, I'd say there's a lot of things going on. Following the recent trends in hair restoration surgery, we're doing a lot more no-shave FUE procedures, which I think is becoming increasingly popular. It's something that maybe a year ago, I would have told patients, listen, we can do it. It can only be done for a small numbers of grafts. It's a very tedious procedure, very time. I would have told you. But over time, obviously, as with everything else, our experience with it and confidence with it has just improved tremendously. And, we've done a couple cases this month of around 1,800 to 2,000 grafts, which I think is a pretty substantial number without shaving people's hair. And I've had some results come in from 6 to 8 months ago, and people are generally very, very happy. So I feel comfortable at this point telling people that, it is a little bit more of a challenging and time-consuming procedure. But if they really do not want to do a strip for whatever reason, they don't want to do it, and shaving their head for social purposes is just too difficult, we do have this option that we feel completely comfortable with at this point. So that's something new.
So I want to touch on that a little bit. First off, I want you to clarify, when you say no shave FUE, are you talking no shaving of the donor area, or no shaving anywhere on the scalp?
So I was referring to no shaving of the donor area. Okay. However, based on what you just said, we do not routinely shave people's recipient areas to implant. So we give people, obviously, if somebody, even if we're doing a traditional shaved donor FUE procedure, we always will give the patient the option of whether they want to shave or not. I know that a lot of clinics like to shave everybody's head, but because my practice and my team and myself are proficient and well experienced in doing strip surgeries where we do not shave anybody's hair, that is not a requisite when doing procedures with us.
Now, does that limit the number of grafts that you will transplant, shave versus no shave, as far as the recipient goes?
No, absolutely not.
Okay.
No.
Interesting.
So I don't make any adjustments based on that.
Okay. And but the real, or the original question I had about the no shave donor.
Correct.
You moved up.
It's not a flap. It's not. It's true
legitimate.
Long hair. Correct. Yeah. Now I do not implant the hairs with the long hair shaft. We do trim them after they're extracted. I found that couple things. I know people like to call it preview long hair FUE, so you can kind of get an idea of what it's going to look like. I think it's very difficult to manage the area afterwards in terms of combing and shampooing. It's just if you comb one and they all start coming out. So I extract them without shaving, and a lot of them will come out with a long hair shaft, but I will trim them before they're implanted.
Okay.
So I don't implant them with long hair. Okay,
that makes sense. So I'm just thinking about it, 'cause I didn't even think we were going to be talking about this, but
me neither.
So when it comes to, and this is just the kind of content I bring you people. This isn't rehearsed. This is actual raw discussion. So my concerns about no shave donor, like, and I do want your unfiltered opinion on this. My challenge with this, when people tell me that a doctor has been offering a no shave donor, FUE is tough enough as it is.
Correct.
So why would you want to put that type of additional challenge on top of an already challenging procedure? I don't poo-poo on it, but it's kind of like, the way I look at it is, if a doctor tells me that I need to do X, Y, or Z to make the procedure as smooth as possible for him or her to give me the best result possible, do it. Shave, whatever. I've always been like that. But I get the idea of not, like, people come in like, oh, I don't want anyone to know. And I get that. But for you as a physician, it's got to be more challenging.
I think that, as with anything, there's a couple ways to answer that question. Mm-hmm. A good consultation and a good scalp examination is really going to give you an idea of what you have to face. And anybody, I will tell you that, if anybody has curly hair, if anybody has a very thick scalp, things like that, I am avoiding doing this in. But for the patient who I feel has incredible donor, straight coarse hair with very well-defined follicular units, I used to make them come in to do test sites before I would actually book them to do the procedure. And without naming any particular device, because I don't want to support any device over the other, but I have for about the last 6 to 8 months been using a newer, I guess, FUE manual machine. Mm-hmm. And I have found that the combination of the machine with the different mechanisms it's able to do and some of the presets, as well as the punch, I have found that not only is no shave FUE, in addition to African American hair and other things, FUE in general, for me, has become a lot easier than it used to be. And so that's kind of to that one comment. And once again, I'm not saying what it is, but I feel like with the device that I'm using, I've had a lot easier time almost surprising myself. So I no longer routinely make no-shave FUE people come in for test sites. I'm not even making African Americans come in for test sites. What I will say is that in a no-shave FUE patient, I am warning all of them that in the beginning, if we're not able to if I feel the graft quality is not as well I would want, you're going to have the choice to shave or to stop. Okay. And, that everybody is being counseled on that. The other thing, just to clarify, this is the minority of the patients that I'm doing in my, maybe, it's not 10, 5%, 3%. It's a couple patients a month that I've been doing with this new technique. The other thing that I think I've done it more commonly in patients with previous strip scars or several strip procedures that have no more flexibility to do another strip, that the thought of having them shave and their scar being exposed really turns them off from doing anything. So I have found that this no-shave option may be a good option for those types of patients, so that cosmetically and socially they're not out and about with their strip scars showing. Right. They say, I'd love to do a strip again, but I say it's too tight and your scar already stretched, you can't do it again. And then, oh my God, I have to shave my head, so my scar's going to show for 2 months. I can't afford doing that. So this is a good option that I have found, especially for, I've done a couple of those cases, which are smaller numbers. Those are 1,200, 1,000, 1,200 grafts, things like that. But it's been a good option for those types of patients as well.
I didn't think about that angle where a patient that has had previous strip scars comes in, the strip is no longer an option for them. I stand corrected. That is a valid approach. I get it.
Now, that's a harder case because he has a scar and the follicular architecture is altered. So I go to your point again.
You got this underneath the...
Exactly. But, that's, I've done several of those. And to your point, I always try and tell people the shaving is going to make it a little bit easier. You're going to get out of here quicker. I know what we're getting, but for the correct type of patient, if some of those, you got to listen to the patients and really find out what their concerns are. Right. And for a lot of them, even though I show them beautiful strip scars and they don't want to shave their hair, they just don't want it. And so this is an option for the correct type of patient, not one that I'm pushing and not one that I particularly love doing, but in the appropriate circumstance, I think that any hair transplant surgeon really, as we've always said, I think should be proficient in all of the technologies and techniques and procedures that are available.
Right. No, that's a great answer, and I appreciate you drilling down on that. Like I said, I didn't even think about the previous strip patient option, where I can't count how many times it's more of an old school type of mindset where the guy comes in and he's like, well, I'm a car salesman and I can't have it look like, I get that. I think that I think that younger patients, newer patients are more pliable in that regard, where shaving is so much of a big deal. But if they've had the strip scar, that makes sense, where they don't want to shave it, because that's one of the advantages with strip is you never had that issue of having to shave the donor. Even places where they make you shave the recipient, they still you just shave out the region of the strip that's being removed. You got the flap of hair, it covers it, or everything's coming together, and so it's automatically just covering the staples or sutures, what have you. So I get it, and that's a good answer. So I appreciate you drilling down on that. Again, it is a toll-free number, 1-833-563-4247. We got Dr. Aron Nusbaum of Miami Hair live answering your questions as soon as you give us a call. Love to talk to you. Of course, it's toll-free in North America and using the calling app of your choice worldwide. I did see some activity in the chat room. Before we get to any phone calls, see if we can get that going on. Let's see. Milk Drinker. Could Joe's hairline even go that low, or would it be on the frontalis muscle? What are you talking about?
I think Joe's hairline is perfect.
I think they're talking about. I just got a haircut today, by the way.
It looks short. Nice.
Yeah, got a little puffiness in the front going on. Yeah. That wasn't planned. It was just kind of a quick a quick blow dry before the show. Let's see, Dr. Nussbaum, how do you determine the lowest possible hairline for a patient anatomically? Good question.
Okay. A couple things. So generally the guidelines, a male hairline should be anywhere from 6 to 9 centimeters from the glabella. So the glabella is the portion in between your eyebrows. Simply by taking a ruler, you can roughly mark 6 to 9 centimeters. Number 2 would be 1 finger breadth above the last wrinkle. So you can have somebody wrinkle their forehead up, and it's not the wrinkle you see here. You got to look because there's also wrinkles on the sides. So you would go 1 finger breadth more or less above the tallest wrinkle. Or there's also the shingling point. So when you turn somebody to the side where the horizontal and vertical axis of the scalp meet, that's another point. All these are just basic guideline rough rules to follow. At the end of the day, it's an artistic sense. You have to look at the patient's facial proportions. You have to look do they have a broad forehead? Do they have a narrow forehead? And really just look at what is done correctly. The frontalis question I know was towards Joe's hairline, but a lot of people will come in and they'll want their hairline at a certain point. I will not transplant anywhere near a wrinkle. So if people are wrinkling up and down, that's too low. But those are just some basic guidelines that you can try and follow. And everybody has 1 or 2 straggling hairs down there where they're going to say, well, my hairline was down here when I was, 18 years old, and that's what I got to look like. And, you just kind of tell them to ignore those, and eventually they're going to fall out. And if you really don't like the way that they look, you can pluck them out. But,
I actually have one. It's right here somewhere. It seems to have fallen out. It's gone into its telogen state, but it goes back every once in a while. The other day, I noticed it was like this long, sticking out. It's like, what the? Go away! Like sometimes you don't want it there. But I'm furling my brow right now. There's my. God, I can't.
Yeah, we're not going that low. We're not going that low.
That'd be another 4,000 grafts right there. My God. Anyway.
Right. And then that's the other thing that I'm glad you mentioned that, you have to look at somebody's overall hair loss pattern. If somebody has hair is a type 5 or type 6 and they have, balding already in the crown, it's not going to look normal to give them this super low flat hairline. Whatever you're going to do, even if you're only transplanting the front half, it has to match with the back.
Yeah. Good answer. I like that. But it's just kind of made me think about it. It's like, just how low is my it doesn't, that would look terrible. Let's see. Who else we got here? Just how much movement is okay on the hairline when you raise your eyebrows? Is it ever natural for the hairline to move up or down slightly? That's a great question.
I don't know. I'm trying to figure that one out. I would say that I'm going up, and I think that the hairline should not be on or over the frontalis muscle or any wrinkles. I think if it moves a little bit up and down just because it's pulling, I think that may be okay, but it probably shouldn't move too much. Would be my answer.
I would say very little.
Very little, if any.
Yeah.
Right.
Yeah. Almost imperceptible. Like it would have to be quite a.
I'm doing it in the camera, and mine's not moving too much. I don't think so.
Yeah, very little. Yeah, good question though. Toll free 1-833-563-4227. We got Dr. Aron Nusbaum out of Miami, Florida, live taking your questions. Give us a call. Toll free North America, worldwide, using the calling app of your choice. See, David Anthony. One wears their hairstyle with very, very short fade, say 0.5 clipper. If you S&P the donor area after the transplant, does overharvesting become less of a concern or risk?
I think the risk remains the same. And so you're saying if he has a procedure done, transplant done, then S&Ps the donor area, I assume the question is, in a subsequent session, is the risk of overharvesting less? If that's the question, then I would actually say, and I've had this, it actually makes it more difficult to harvest once the area is already S&P. So when people come in with S&P in the donor area, you're under your big loops, and I think it makes it a lot harder to see what you're doing in there. So I usually recommend patients, if they're going to consider doing S&P, I like for them to wait until all their procedures are done, and then I can tell them that it's something that they can go ahead and consider. But I don't think it replaces, it's not a solution for, don't worry. And I've had people come in and say, don't worry, you can take all the hairs on the back of my head and I'll just S&P it. I mean, the S&P is not a way to promote or allow over harvesting is whatever.
No, it's that brings back a memory where I had an assessment, and the estimate was influenced actually by the S&P I'd had years ago in my donor area, which actually spoke to the quality of the S&P. It was actually trichopigmentation. It spoke to the quality of the trichopigmentation I had, but it didn't bode well for the actual assessment or the day of surgery assessment, because we had to bring down the game plan because of that. So it is what it is. I understand. People want to. I find this interesting. They want to proactively or pre-treat an area, like with hair restoration. You'll see. I want to place grafts in an area for when I lose hair later. I liken that to filling up a glass of water that's already full to deal with future evaporation. It doesn't make any sense.
It's a good one.
I mean that's the response I would give when people would come at me and say, yeah, well, why can't we just put more in the like if they had a strong forelock with native density, why can't we just fill in this area for when that forelock actually falls out? It's like, huh? It doesn't compute. It doesn't work like that. Okay, let's see here. So, any other questions? Guys, we got a lot of questions coming in the chat room, which we certainly appreciate, but this is a call-in show, and as always, if the calls don't start coming in, I will be shutting this down so that Dr. Nusbaum and I can have our own private chat, and then he can get home to his wife and his new baby. Number is toll-free, 1-833-563-4247. Give us a call, and of course, using the calling app of your choice worldwide, you got Dr. Aron Nusbaum here to answer your questions. Let's see, how do we treat severe okay. Yeah, this is something I do want you to address. Crown Zach says, how do you treat severe seborrheic dermatitis before after a transplant?
Okay, so a couple things. Seborrheic dermatitis, the first thing is it really seborrheic dermatitis? Mm-hmm. Is it scalp psoriasis? Is it masquerading itself as lichen planopilaris? So aside from that whole conversation is, because the most common misdiagnosis of lichen planopilaris associated with androgenetic alopecia or fibrosing alopecia in a pattern distribution, as we're calling it now, the most common misdiagnosis is androgenetic alopecia with seborrheic dermatitis, and that's been published. So number one is making sure you have the right diagnosis. So assuming it truly was seborrheic dermatitis, what I would do, let's say I was seeing somebody in a consult and I saw that they had seb derm, I would typically prescribe them a medicated shampoo like Nizoral 2%. It is prescription, not the 1% over the counter. I'd have them use that, and I like to see that patient about a month before surgery. So he would come into the office for a second consultation a month before the surgery, and then depending on whether it was controlled or not, I may add a short-term topical steroid like clobetasol to the area once daily for about 2 weeks preceding up to the procedure, because you do want the scalp to be clean or clear of that before you do a transplant. So the best thing to do, and I've had to cancel patients, sometimes you don't notice it until you shave their hair, their donor area, but oftentimes, usually with a combination of topical anti-inflammatories, topical steroids, and some medicated shampoos is what I would say.
Right on. How do you feel about tar-based shampoos?
I don't mind them. I prefer if somebody has really thick thick scale. I like a sal acid shampoo a little bit better. So my first line, I usually start with ketoconazole. Then sometimes I'll alternate it with Neutrogena T gel. And if that's not taking care of it, I'll go to T-Sal, which is salicylic acid, I believe 2%. If that doesn't do it, there's something called Sebex that has some sulfur in it as well. But I'm not crazy about the tar. I mean, they can certainly be used. It's just not my routine go-to.
Right. Okay. Fair enough. Because I actually had this issue years ago, and it was a tar-based shampoo that helped me get it under control.
Correct.
But yeah,
it's a standard of care in dermatologic, scalp disorders and stuff.
Right,
so.
right. Fair enough. Okay, so everyone, 1-833-563-4247. It is toll-free North America, and using the calling app of your choice, we got Dr. Aron Nusbaum live to answer your questions. As always, if we don't start getting some phone calls, I'm shutting this down and letting this doctor go home to his family. It is 3:29 Pacific time here on Monday, June 26th. Someone said you should put the number on the screen. You're right, I should. So let's just do that. There we go. So over here, right. Yeah, there you go. Wait, over? There you go. There's the number. Thanks for the assist there, Doc. 1-833-563-4247. Sometimes it's like, trying to remember everything I need to do for the broadcast. It's like I'm getting better at it. And that the logo with a phone number is becoming pretty much the last thing I need to remember to do, and I'm almost there. So thanks to Milk Drinker for reminding me of that. Let's see what else is going on in the chat. We got some people watching. That's good. Give us a call. It's 1-833-563-4247. Sergey in the chat room says, what is Dr. Nussbaum's definition of the so-called X factor that affects graft survival? What exactly does this factor consist of? Fair question.
I think it's exactly what you call. I think it's the X factor. So I think it's not all of the known things that that's always been a tough one for me, because I can sit here and list all of the things that we all know that may affect graft survival: desiccation of the grafts, over manipulation of the grafts, overheating of the grafts, you name it. But the due to an inflammatory scalp disorder that was misdiagnosed. I think the X factor is kind of where you cross all those things off of the list and you still don't have an explanation. I don't know how much I really believe in that one, I guess, just because I feel like how can you really go back and tell, did any of the grafts dry out? Did you have them at 4 degrees the whole time?
Right.
So, yes, you can certainly look at somebody's scalp, do a biopsy, and confirm that they don't have alopecia areata or lichen planopilaris. You can, say I have technicians that have been working in my office for 20 years and everybody's hair grows every single day, so I can't imagine that they would have over-manipulated the grafts. But unless you're literally video recording which nobody's doing, every single intricate, hundreds of steps of the procedure, how can you ever really say that none of those things happened? Yeah. So I guess my speaking about it and thinking about it now is that a really real thing, or is it just that we don't have an exact answer for why the hairs didn't grow as well as we would like?
Well, we don't know what we don't know. Right. And, what I thought about this a lot over the years, because, everyone runs into a case where it's like, why, Right. You look back at the surgical chart. You look at all the notes that you made as the primary surgeon. You look at all any notes that were contributed by your lead technicians, and not talking about you specifically, but in general, better clinics. And if you can recall the case, because it's a year later, if a patient usually when a patient's coming back and saying this is happening or that's happening, and you're struggling to remember the patient because you've had a couple hundred maybe since then. So, it's I say this to patients. Here's something to consider. When patients are unhappy with a result or something, and say there's something some area that didn't grow properly. The idea is that if you send photos into the clinic's going to be able to look at it and say, "Oh, that's what happened. Now I get it. Yeah, this is what happened. This is why I didn't grow." It doesn't work like that. It's basically the X factor with every case. No one knows unless you can look back in the surgical chart and you say, you know what? He's a bleeder. There's some popping going on. Maybe there's a little bit too much, handling of the grafts. So maybe there is just a little too much trauma on the grafts in this area. Okay, that makes sense. That's what physicians can recognize. But if it's a normal looking surgery, it's anyone's guess. Even if we have photos of the results, like is there some sort of dermatological condition that arose that we can see? No. Is there a need for a biopsy to actually dig down into this? That's pretty much the only way to do it. And even then, it's pretty inconclusive on most cases. Would you agree with that?
Yeah.
Yeah. It's so back to the question, what is the X factor? It's anything that we can't explain as to why a result doesn't turn out. And that's basically it. We don't know what that X factor is because like you said, Doc, it's X is the variable. We don't know what the variable is by definition. So yeah, I mean it's a good question.
Patients don't like hearing about it from the one or two times that I've heard some of my colleagues had the discussions.
Yeah.
But I think a lot of times the best that you can do is just, if that happens to you, is hopefully the surgeon will acknowledge that he is just as unhappy as you are, and hopefully it's something that he takes care of for you.
Yeah, exactly. All right, so what else we got here? It's a toll-free number, people. Numbers on the screen. It's 1-833-563-4247 in North America. You can also call worldwide using the calling app of your choice. We had Andrew Vernon asking how I can call on WhatsApp from the UK. You should be able to dial the number, I think. I don't know if WhatsApp can you dial numbers that are not in your contacts. I don't think so, actually. But if you have Skype, you should be able to do it because we get a lot of calls from we get them from Poland. I think our guy from Azerbaijan, Kazakhstan. That's it. I think he's using Skype, or maybe not. But if you want to talk to Dr. Aron Nusbaum, there are ways. I just don't know what all the ways are. If you're in North America, it's toll free 1-833-563-4247. You're having difficulty calling. I don't know what those difficulties would be. Are you putting in country codes or do a Google search how to call a U.S. toll-free number from the UK, because I know you're in the UK. Give that a try. What else we got here? Has Dr. Nussbaum seen patients react better to topical finasteride/dutasteride and minoxidil versus the oral versions of each? Good question.
Okay, so have I seen topicals? No. The answer is no. I still believe that the oral versions, I guess let's call it let's talk about finasteride and dutasteride. I still feel like the oral are superior to the topicals. I think the topicals are effective from what I've seen. And I think I mentioned this the last time. I was very hesitant to start using topicals for many, many years in my patients. I felt like it wasn't going to be absorbed sufficiently. And I just kind of said, poo-pooed the idea and said, unless you have this special nanoparticle delivery system, like I think is available in some places in Europe, I'm not sure how well it's going to absorb and work. I had patients really push me to try it, and I did. Mm-hmm. And I make a combination similar to what a lot of is commercially available. I use finasteride, minoxidil, a little bit of retinoic acid, or tretinoin actually, and a mild anti-inflammatory. And I have been surprised with the results, but I am not anywhere near to the point to say that it is more effective than the oral versions of the medications.
Okay. All right. And then what are your thoughts on oral minoxidil versus topical?
Okay. So and that's something that has gained a lot of popularity and ask people. I generally am a quite conservative doctor when it comes to surgery, when it comes to prescribing medications. What I will say is I have a lot of people on oral minoxidil, and the overwhelming majority of them are doing well without any side effects. However, it is a dangerous drug at high doses. Mm-hmm. So I think that at the doses that I am comfortable giving, which is really no more than 2.5 milligrams a day, I don't even go up to 5, I do not think that it is superior to 5% minoxidil twice daily. I do think that it increases patient compliance because people are more willing to take a pill than put a topical on there. And I do think that if you found a doctor who was brave enough to use 5, 7.5, 10 milligrams of oral minoxidil, which I don't know if many people are going above 5, I'm sure that would be more effective than the topical. So, but at the doses that I'm willing to prescribe patients to where I know I can sleep at night and people are not having cardiac side effects, which is kind of a big deal, I do not personally think that it's more effective unless the patient says, listen, no way I'm putting stuff in my hair twice a day. Then I think it's something worth trying. I start women usually at a quarter or 0.625, and I'll bump them up to 1.25. Men, I start at 1.25, and I'll go up to 2.5. Okay.
Fair enough. That's a good answer. I appreciate that. Toll free 1-833-563-4247 using it's toll free North America. Calling up of your choice worldwide. We got Dr. Aron Nusbaum on the line, or on video live on the line, on video live to take your questions. We also have, we got a phone call. Let's see, who is this? Okay. Hey, you're on the main event. What's your name and where are you calling from?
Hey, good afternoon. This is Stan. I'm calling from Hollywood. How are you?
Good, Stan. How are you?
I'm doing well.
Right on. Dr. Nussbaum, you can hear Stan just fine?
Hey, Stan. How are you?
I'm doing very well. Thank you for taking my call.
Awesome. Awesome. Thanks for calling. What can we help you with?
Okay. Well, a comment on a couple things you guys said a few minutes ago. You mentioned something about somebody being a bleeder and how that can affect their results.
Yeah.
So that kind of struck a chord with me. I'll give you a little background. I had surgery about 15 months ago. And I was about 5A at the time, and we decided to do the front and then the crown at the second surgery. So when I was about to have that first surgery, I had a routine blood test. I think they did a CBC before that, and said I had low iron. And then, so the doctor told me, hey, take some iron supplements. We'll keep you scheduled. Everything went through, had the surgery, everything went according to plan. And then when it was time to book my second surgery, same thing, had a CBC, low iron, but this time the doctor canceled. So, right now I'm kind of going down the rabbit hole trying to figure out why I have that low iron, trying not to get sort of like tweaked about it, by being rejected and all that head trip that goes along with it. Obviously I want to be safe. And so, I'm kind of like in this no man's land right now where I'm trying to figure it out. I'm doing full cardiology workouts. Mm-hmm. I'm doing gastro testing. I'm not exaggerating. In the last couple months, I've had tons of tests and, blood work and going to specialists and all this stuff, taking iron supplements. So I kind of wanted to get your opinion on that. Why would I get rejected for low iron on the second time, but not the first time?
Okay. I have a couple of comments here. So I know you said they did a CBC in iron, but usually, what they really need to be looking at, the most important, did you have bleeding during your surgery? Like, did they tell you bled a lot, or were you happy with the results of your first procedure? Not that, make you answer too much, but do you remember them telling you were bleeding a lot during the procedure the first time, or?
So the answer to the first question is no. They didn't actually tell me that I was over bleeding or anything like that. Mm-hmm. I do take a blood pressure medicine, and with that combination, that maybe could be a problem. But my blood pressure has been controlled with the medication. That's fine. I'm on a very mild low dose. And, so as far as the results, that's an entirely other conversation. I can say that generally, I'm super happy with the results.
Good. Mm-hmm. Good. Okay. So here's sort of to answer your question. When we think of pre-surgical or intraoperative bleeding as a doctor, we're worried about a couple of things. The lab values that really you're looking at a platelet count, which is in the CBC, and you're looking at the coagulation factors, which is your PT or your PTT. So those are the main things that are going to determine somebody's predisposition to have excessive bleeding in the procedure. Obviously, in addition to screening them, have you ever had a bleeding tendency? Have you had previous surgery, easy bleeding, bruising, those things? So if your PT, PTT, and your platelets were normal, that's okay to kind of move forward towards surgery. Now, in the case of, and I am not a hematologist or an internal medicine doctor, but from what I know and recall from all this, low iron is usually an indication of bleeding somewhere else. Most often it's GI sources, usually from a GI bleed is usually the first thing you look at. And what I would say is, if your hemoglobin was normal and you weren't quite anemic and you weren't having iron deficiency anemia, which I have canceled patients for that before, I'm not sure that in and of itself, depending on where your iron was, would I had canceled the surgery or not. So, if somebody's hemoglobin, hematocrit was normal, platelets were normal, CBC was normal, if their iron was a little bit low, I don't know that in and of itself would have led me to canceling a procedure. Obviously, without looking at the exact values of all these things, that's just kind of a general answer that I would give you. Mostly in when you have low ferritin, which is a measure of your iron stores, especially in women, that is a cause of telogen effluvium. So in a woman, I routinely check for iron and ferritin levels preoperatively. And if somebody had a low iron or ferritin preoperatively in a woman, I would delay their surgery. In a man, I don't routinely check those things. I check what I told you, CBC, which is with a platelet count, coagulation factors, PT-PTT, a complete metabolic panel looking at the kidneys and the liver, and I also check an infectious profile. The other thing that's interesting, I don't know whether they made you get a clearance or not, but anybody in my office who is over the age of 50 or anybody who has even taking a blood pressure medicine, I make them get a preoperative clearance before I operate them, from the beginning.
Yeah, and that's what I'm in the process of doing right now. I definitely, I know for sure that they said that I was anemic and low iron. Some of the other terminology, I'm trying to keep up with. I don't work in the industry, but that's okay.
But if you were anemic, and had low iron, I have canceled patients for that.
Okay, and that's why I got canceled. Now, for a while I was kind of dealing with it, sort of the mental state of rejection. I reached out to a couple clinics, and of course, there's always somebody that's willing to do the surgery, but my preference is to stay with my original doctor and get this cleared for safety. And so that's where I'm going right now with the GI. They're scheduling me for an upper and lower GI to get a scope done. I've done a nuclear at the cardiologist. I could go down the list of all the testing. I've done calcium scoring on a CT. Like I said, tons of blood testing. It's tough walking around with half of a hair transplant. But obviously I want to be safe.
Yeah.
Are you a vegetarian or no?
No, sir. I'm also wearing a leather belt. I have no problem with that whatsoever.
Okay. Just I got to check. So, because that is a big cause of low iron,
Uh-huh. Yeah. And, so I'm just kind of going down the rabbit hole. I want to be safe, but I definitely want to get this surgery done because, like I said, I'm walking around with half of a transplant. So it would seem. Any other recommendations for what I can do to?
No, I think you're doing all the right things. I would tell you I know it's not true medical advice because I don't know the whole story of the case, but what I would say is iron deficiency or iron deficiency anemia is typically a pretty common thing. Most of the patient, they will find the issue of what it was, and resolve it, whatever it is. And with some iron supplementation, you should be able to bounce back from this, whether it's oral or IV. So I don't think that, this is more of kudos to your doctor for putting the brakes on the procedure and doing this medically soundly the correct way. But I guess the reassurance, soft reassurance that I can give you is you will be able to do your procedure at some point. But I think this is the correct course of action. anytime anything else is going on medically, this is an elective procedure. And while I know the feeling of waiting for that second surgery, rest in confidence that this will not be a permanent rejection or blockade. You will be able to get it done.
Yeah, I appreciate that. And just real quick, I don't want to jam you guys up all day, but just real quick, you said something about getting a cardiology clearance of some sort. Is there some sort of surgical clearance form that I need to obtain?
If your doctor, everybody does things differently. Some people don't check labs. Some people don't require any clearances. I make anybody over 50, and that's just my arbitrary number. I make anybody over 50 and anybody with any history of any cardiac problems, including high blood pressure, get a clearance, because I don't want patients to show up the day of my surgery and their blood pressure be uncontrolled and we have to send them home or anything like that. And you'd be surprised. I've found normally thought they were completely healthy 49, 50-year-olds who go in for an EKG and it's abnormal, and their cardiologist has to cancel the surgery because they have something going on. So not trying to scare you, but if you've already been operated on, your blood pressure's under control, and you've already had, it sounds like, every cardiology test known to man, not known to mankind, but several of them. I don't think that personally, I don't think that that's the reason for your iron issues. And if your surgeon, whether he requires you to check a box that you've done that or not, that's up to him.
Got it. Okay. Well, I really appreciate the advice. I'll just keep doing what I'm doing, and hopefully I'll get cleared eventually. And appreciate
you will
all your advice and help.
And I'd like to say also that it's good to hear that your doctor had your best interest in mind when he's saying, look, we did the first one. You're happy with the result. Great. We'd love to do the second one, but it's just not a good idea. I look forward to you calling back to tell us how you got it worked out, and tell us that you've been accepted for this procedure and it all works out in the end.
Okay. Yeah, I'll keep you updated. And thanks again, gentlemen. Have a great afternoon.
All right. Take care.
Best of luck to you. Thank you.
Bye now.
Bye-bye.
Thanks.
1-833-563-4247. That was a good call. It's a great question when it comes to blood work. A lot of clinics don't actually require blood work of any sort. They'll ask the basic questions. Do you have cardiac history in your family, and do you have these issues or that issues? And that is usually an indicator to the doctor to ask questions that can lead down that rabbit hole. But most clinics don't actually require the blood work, and I think it's. Look, you're checking all the boxes before you actually have a surgery, and I think that's a good thing, especially with what you're just talking about, Doc, where you've had some seemingly healthy and fit patients come in realizing that, there's something that needs to be done here, aside from hair transplant surgery. And you probably saved their life by requiring that test,
Yeah. I mean, I've also, interestingly enough, I don't know if everybody medically knows, I've found, 3 or 4 patients with bleeding disorders actually that have true variants or traits of hemophilia, which is people that do not clot perfectly. And I mean, that would have been a disaster if I operated on those patients.
Exactly.
And we've actually diagnosed 3 or 4 of them. So. Oh,
wow. Yeah, well, good for you. Good for you for for running things the right way. That's good. Toll free 1-833-563-4247. We got Dr. Aron Nusbaum live on the show to answer your questions, and I see a lot of activity going in the chat. We'll go ahead and jump back on there, and I'm noticing there's more discussion about the frontalis muscle. Philly Boy Fitness. Maybe you didn't see the discussion earlier. He goes, "How does the frontalis muscle come into play when how low you can go with the hairline?" If you want to touch on that,
avoid it.
Yeah, just avoid it. Yeah,
avoid it. If it's moving, you don't want to go there.
Yeah, exactly. I've seen some guys that have actually had that done, and when they're talking about their results, they're doing their just normal facial expression. The hairline's moving with their eyebrows. It's extremely distracting. It's like, I can't look at this anymore. It's just terrible. So avoid the frontalis muscle at all costs. Okay, so Ralph has got a good question. Can hypothyroid cause hair loss, and can synthroid help?
Okay, so
Great question.
hypothyroidism absolutely can cause hair loss. Most commonly, thyroid disorders are associated with telogen effluvium, is what I would say, which is basically a temporary shedding episode. Now, and that's something that we look for a lot in men and women, etc. But if somebody has a pre-existing diagnosis of androgenetic alopecia, anything that can cause telogen effluvium theoretically can make the androgenetic alopecia worse by exacerbating it. And a lot of times that underlying metabolic or hormonal disorder can unmask, or that telogen effluvium can unmask and start sort of the cascade of having androgenetic alopecia. So the short answer is hypothyroidism absolutely can cause hair loss. It can either cause shedding or exacerbation or unmasking of androgenetic alopecia. And as always, treating the underlying cause with something like Synthroid or levothyroxine should at least eliminate that factor. Now, do I think that if somebody lost a bunch of hair, if they had androgenetic alopecia and they were found to have a thyroid disorder, would correcting the thyroid disorder by itself completely reverse their hair loss? Probably not. It would probably slow the shedding down, but I still think if somebody had true miniaturization under the dermatoscope, they would still need to use the traditional, hair loss medications that we prescribe to our patients.
Okay, that's actually it's quite the comprehensive answer. That's good. Who else we got here? Okay, guys, enough questions about the frontalis. It's like just it's enough. And you can define the border or where the frontalis is by the furling of your brow, and you can see the outline where the brow ends, and then it's still smooth. So right here, for me, is the frontalis muscle. I guess that's right. Would that be right, Doc?
Yeah.
Right around here? Yeah. So, enough of the frontalis.
But it has bands that go all the way,
Of
here,
course.
so.
Yeah, of course.
Right.
Okay, so what other questions we got? Have you ever had a Philly Boy Fitness? Doc, have you ever had a transplant yourself?
No. I've been taking finasteride and dutasteride since I was 18 years young.
Wow, you got on it quick. Good man.
Yeah.
Good man. Let's see what else we got here. While I'm looking for more questions, it is a toll-free line. Give us a call, 1-833-563-4247. You can ask Dr. Aron Nusbaum questions directly about anything that you have questions about, anything you want to know about with regards to hair loss and hair restoration. Mark?
Or life in general.
Or life in general, yeah. Fatherhood.
Let's open it up so maybe somebody will call,
Exactly. Let's see. Andrew Vernon, I had gastric sleeve surgery 5 years ago. I had hair loss as a result. Nutrition depletion, maybe?
Yes, so after gastric surgery, whether it's gastric bypass, gastric sleeve, a lot of those patients are severely deficient in many of the vitamins and minerals, is what I would say, which absolutely can contribute to, hair loss. So, though I'm sure hopefully the surgery went well and hopefully you recovered and hopefully you're feeling well, particularly people are usually very low in iron. I've seen zinc. Certain things like that. So it's definitely can accelerate hair loss.
Right. Good.
And I have seen that several times.
Right on. Let's see. Any other questions here? We got, let's see. So this is the part where it's kind of tough because I'm scrolling to look for questions, but there's a lot of conversation going. In the meantime, guys, toll free 1-833-563-4247. You can give Dr. Aron Nusbaum a call and ask him questions about hair loss, hair restoration, and life in general. I love that one. That's a good addition. Let's see. Any other questions? How do you always do a more conservative? Okay. Do you always do a more conservative hairline on patients in their 20s?
Okay. So, 20, I guess the first thing I'll say is yes, but, somebody who's 21, I'm probably not operating on them. So I want to be careful with saying in their 20s, but yes, assuming in their mid to late 20s, and they're on the appropriate medical therapy for stabilization, and you've seen them take those medications for some time and documented that they're not losing any more hair, you typically do want to opt for a more conservative hairline in a young patient, even in an older patient. I am of the sort of belief that you can always lower it and bring it forward. And I always try to take the more conservative approach, especially in a younger patient. So I have issues with people that try to force me to make their hairlines too low, and it's not even too low. They just want it kind of that flat look, or they want the corners blunted. I won't do it. So
Right.
that's even more important. Now, if you have a 55-year-old man who has this great head of hair and just says, I want to lower my hairline a finger breadth just because, as long as it's not on the frontalis muscle, and as long as the corners, he's willing to accept a normal right angle male recession, not sort of a blunted corner, I'm fine with it.
Yeah.
But in a young patient, absolutely.
Good answer. Good, and that's actually what a lot of the better doctors will say, is that it's always easier to lower a hairline later as opposed to raising it later. So it's always a debate, and not every doctor actually agrees with that approach. I know of doctors that will say, yeah, we can be more aggressive because of the way that we can assess the future loss, and we'll get into that in a second. Hang on. Hey, you're on the main event with Joe and Dr. Nusbaum. What's your name and where are you calling from?
Hi, Joe. It's Karen from Dallas.
Hello, Karen from Dallas. How are you, girl?
Great. I'm really excited that Dr. Nusbaum is with you. Great answers. I wanted to ask a question. He said open it to anything. And he mentioned that when he is prescribing for women, he tends to go more conservative with the dosage. And so that kind of opened the door. I want to know what percentage in general his practice involves women for hair loss issues and even hair transplant surgery.
Wonderful. So, very nice to meet you, Karen. Basically, we have two arms to our practice. The first arm, obviously, is hair transplant surgery, which I would say is probably 25% female. Okay. I love doing facial framing in women. I think it's an artistic procedure, and I actually love doing it. My father was one of the first people way back, probably 20 years ago, to describe naturally occurring female hairline patterns and the different measurements and the lateral mounds and the different recessions. So I've kind of taken off of that, and it's just something that I think I have a special interest in, and I really do love doing work on women, especially, facial framing. We obviously do work in women with androgenetic alopecia. Those are the patients that I love to be on medical therapy to exhaust those options first before we jump into transplants if they actually do have true thinning throughout the top. But for women that are mostly concerned with temporal recession or a little bit of frontotemporal hairline work, I think the results of transplants are beautiful, and I think it's a great option for the women that are candidates. So a lot of women I find are dying to have a transplant, but as we know, the thinning oftentimes is diffuse and it involves the donor area. So a lot of times the women that would really benefit from it most or want it most or need it most, unfortunately, are not the best candidates to do it. The other arm of my practice is simply medical, non-surgical medical hair loss therapies, which is basically where it's a one-on-one visit with myself or my associate, Dr. Wu, who's a board-certified dermatologist, as am I. And basically it's an hour-long appointment where all of the medical history, lab work, everything is reviewed. There's a thorough scalp examination done with dermoscopy, and different measurements are taken throughout the scalp to follow their density, standard photographs, and we review all of the different types of non-surgical options for women. So that's a whole nother arm of my practice. And I would probably say 70% of the women, 70% of that practice is women.
Wow. Awesome.
So we treat a lot.
That's fantastic.
And usually, I mean, with some of the combinations of the therapies and the different things that we do, I usually will tell a woman with androgenetic alopecia, we are able to get about a 20 to 25% improvement in density with certain therapies that are non-surgical that we offer, which may not sound like a lot, but visually is a substantial number.
Oh, yes. That's fantastic. You know, I mean, this is a great show, and I log in all the time, and my husband's dealing with his own hair loss issues. I'm not particularly, but he is, and he's going to see he's going to get a consultation here in Dallas, but I'm going to tell him how great you are. So if he wants to take a trip to Miami, you know, but doctors don't really talk much on this show, or Joe doesn't, about women. And I know it's not discriminating. It's just the people that come are mostly men, but I'm always fascinated to know, you know, what percentage of the practice that doctors like you have, you know, the really great doctors that are women. And I'm very excited to hear how many women you work on, and that you do a really great job with the surgeries that you do. So that's very exciting. Thank you for telling me about that.
Thank you so much.
And thanks for the show. Yeah, thank you. Thank you for being here, and thanks, Joe.
Thanks, Karen, for calling. As always, thanks so much. Take care.
Okay, bye.
Bye-bye. Karen's always a great caller. We appreciate her support. Toll-free number is 1-833-563-4247. It's toll-free North America and using the calling app of your choice worldwide. And while I'm on the subject, don't forget to like this video because it's a great one. We got Dr. Aron Nusbaum of Miami Hair in, wait for it, Miami, Florida, live, taking your questions and talking about hair restoration and hair loss and whatever else you want to throw his way. And if you're not a subscriber to the channel, if you want to take part in the always lively chat that's going on during these shows, you have to be a subscriber. So hit the subscribe button, and while you're at it, ring the bell for all notifications so you are notified of all videos, the live streams, and the pre-recorded stuff that I do upload as well. We got Dr. Aron Nusbaum taking these questions. Let's have a look in the chat, see what else is going on. Do sharp temples tend to look better than blunted temples? That's a good question. It's kind of general, but what do you think, Doc?
Temple points, I'm assuming.
Yes, I believe that's what he's talking about.
I like them a little rounded.
Yeah.
It's my personal preference. I don't like now I've had people, you know, not force me, but I want this arrowhead point, and I'm, you know, trying to tell them it doesn't really look so good, but I prefer the sort of rounded approach. I think if it's too pointy, I think, you know, as Joe has touched on, I'm sure several times, the temples are tricky. They're an area, if you don't know what you're doing, I mean, no matter how good you do everywhere else, you know, it's going to be noticeable. You have to use a lot of single hairs in that area, and you may even tell the patient they may want to come back and thicken it up a little bit more because using singles in there, you got to be super, super careful with the angles and direction. But just to give you my answer, I prefer a little bit more of a rounded, blunted temple point than a sharp one. Yeah, and to Milk Drinker, he's just asking. He goes, I thought you just said you don't do blunted temples. He's talking about temple points. It's two different things. Right. So in this is what I would call the frontal, backwards here, the frontal temporal recession. Now, mine is my own hair, so it's a bad example. But, you know. You're just bragging now. When we're doing a transplant, I don't like this to be blunted and cut off. That's what I'm talking about in terms of not blunting the temple. When we're talking about the temple point, I like that to be more of a rounded shape than a sharp triangle. Yeah. I hope that answers your question, Milk Drinker. Because sorry. They are. No, it's not your. It's a very common misconception when patients are doing their research. Is a lot of times it's not even broken down very clearly. A lot of times on websites when someone's talking about temples, temple points, they don't discern which is which. So I don't blame patients for being confused. Yeah. Yes. Yeah, absolutely. Let's see what else we got. Mark of the Austin Stone, what's wrong with a flat hairline? Doc? What's wrong with a flat hairline? You have one.
Who are you to say
it's
that I
not that
can't
flat.
have one either?
Come on. I'm thickening a little bit in the corners. I mean, there's nothing wrong with it. I think in certain types of ethnicities and certain types of groups and, certain individuals, I guess that may exist. But look, generally people that are coming to our practice for hair transplants, have a significant or noticeable amount of hair loss. Very rarely do you have the person coming and saying, I know that my hair looks great and I'm a shampoo model, but I just want my hairline to be lower. Like some people you do have people that come and just say, look, I have a higher forehead than others, and I want to bring it down. And I suppose other than sort of some types of ethnic groups or somebody that has tons and tons of hair that really is not having any signs of androgenetic alopecia, is just trying to cosmetically lower their hairline, that would really be the only appropriate time to maybe consider not a straight hairline, but more of a flat hairline. Was the question straight or flat?
He said
straight
flat.
Is a whole nother story. Okay,
Yeah.
Flat, good. So that would be the only time that I think it's doable. And I always tell people, especially in the younger patients that want it, what's going to happen if 5 or 10 years you start losing behind that, and then you have a big, anybody who has a big spot in their crown doesn't have a low, flat hairline, broad hairline in the front. So you always have to worry about what's going to happen later. So
good answer. And
I don't think it looks as natural. That would be the last thing that I would ask. Well,
it's hard to create that naturalness as well, because when you have those types of hairlines, there's always going to be it's hard. Like there's always going to be the little finer hairs that kind of soften.
Stragglers.
Yeah, the stragglers. Yeah, and it's hard to recreate that when you're doing the more recessed hairlines that are typical of non-juvenile hairline sporting guys. It's easier to deal with that, but I mean, it's still difficult, but it's a different ball game, a completely different ball game. And so I not a lot of people understand that. And I mean, these are the nuances that are just so difficult to get across unless you're actually putting on a seminar with graphs and things that you can, graphs being, diagrams that you can point to and really, really discuss. But let's see, what else we got here? Let's see, Joe got the doc on. Help us see more questions. Nico F, what percentage of Dr. Nussbaum's patients have been repairs, including tough donor repairs? Okay.
10%. 10-15%, I would say. I just did 2 patients last week that went to a clinic locally here that's offering, I think, $2 graft transplants, and 2 young gentlemen that really didn't need a transplant, in my opinion. Their natural hairlines look just fine and age appropriate for a 27-year-old guy. They got this super low, flat, straight, thin hairline, and I had to do, I think it was like 340 removals on one guy the other day. He's going to have to wait 6 to 8 weeks to then maybe come back if he needs a second session of removals, and then maybe to put some singles to feather in and kind of camouflage some of the bigger grafts that are still there. So the donor area I'm seeing more of recipient area, too low, broad, flat, thin hairlines, or misangled or misdirection grafts, I guess that I would say, than true donor repairs. I think there's one thing to repair a stretched strip scar, either with a combination, that I think is easier to do than somebody who's been over harvested with FUE, because an over harvested with FUE, that's really, really tough. I mean, you can try to put body hair, you can try, SMP, but you're not, where are you going to get the hair from to fill that up? And then I also think another thing that people don't understand is to match the actual angles in the donor area and the natural gradual transition that the hair naturally is extremely, extremely difficult. So that's something when people have these big wide strip scars, that's why a lot of times, sometimes we try and just do a scar revision first, shrink the scar a little bit, because if the scar is a centimeter, yeah, you're going to have hair back there if he's trying to wear his hair long, but if he's wearing his hair long, then he wouldn't be coming to you anyway. So these people have a big scar. They're trying to shave their head, and you don't want to you want to try to match the gradient. It's very, very challenging to do.
Yeah.
I would say it's about, probably 15% of my patients, but mostly for poor work that's done in the recipient airline or the hairline, more so than the donor.
So about 15% of your patient load is repair.
And a lot of times people don't want to get rid of their, it's very frustrating for me because a lot of people come in with 2s and 3s in the front, or they're going the wrong direction, or they're too low, and they don't want to go through the removal phase. They're just like, oh, can't you just camouflage it, or it's not bothering me, so can't you just go around it? And that to me I never really understood that one.
Let me ask you.
I opened up the topic.
That brings up a question. How do you see when those patients come in and you're looking at it and it's screaming hair transplant, and you know that everyone that sees this person can see that it's a transplant because misangled grafts, bad directions, multis in the hairline, every issue that can go wrong goes wrong. And they just want it filled in for density. You're in a tough spot, because when you fill in that area as they requested and it still looks like a transplant, your name is all over that. And people say, where'd you get the transplant? And they're like, well, Dr. Aron Nusbaum. And you're suddenly the plug doctor. How do you wrestle with that?
This comes back to our hairline issue, and positioning issues. So I always tell patients, the best that I can recommend you to do is let me start with a clean canvas. Let me extract the grafts. People are always worried about scarring from graft removals. It's actually, they heal beautifully. If you use a small enough punch, sometimes you even suture and leave some sutures in the little punch holes for a day or two and take them out. Because it's forehead skin that heals great, there really is no long-term visible scarring or dots that I've really appreciated from graft removal. So that's one thing that I would tell people not to be scared of.
Right.
Number two, if the patient is adamant on, I don't want removals, I don't want to pay for removals, because it's like paying for something twice. I don't want to have to wait, to do it, which I think is, absurd, because most busy surgeons, if you're going there, they're not going to be able to do your surgery next week or next month anyway, so you're going to wait for them regardless. Yeah. But I will look, if the hairline is, let's say there's multis in the front, if the hairline is high enough to where you have about a centimeter or a half a centimeter to be able to work in front of it and just put 400 or 500 singles to try and camouflage it, that's the only time that I would say that working with it is acceptable. I mean, at the end of the day, you're trying to listen to your patients, you're trying to listen to their concerns, and as long as what they want to do is not blatantly incorrect, sometimes you have to bend a little bit. Yeah. But if their hairline was at 6 centimeters, which is the lowest point that I think a male hairline should be, and I don't have enough room to camouflage it, either you're going to let me take the grafts out or I'm not doing it. And I just say, I think you should get another opinion. This is my strong belief. This is what you should do. I understand what you're telling me. I understand you're going to have to wait longer. I understand it's going to cost you more money. And I'll just flat out tell them, this is my reputation. And, I'm not comfortable doing what you're proposing. So I think you should talk to a couple other doctors and see what they think. And this is my best advice for you as if you were my relative.
And I think that's important because too many times people will come in and they're like, well, why won't you do what I'm paying you to do? And I'm a firm believer, actually, that when patients come in and they don't recognize the disaster that's on their head, and they just look at one of the shortcomings of being low density. I think it's a doctor's responsibility to do what you said, to seek out a second, a third, a seventh opinion until that patient gets keeps. I don't want to say keeps getting told the same thing, but that's basically it, where, eventually someone will get it in their head that what they want is not in their best interest. And some people, they're not going to get it. And there's a saying, I don't know if you've heard this yourself, but if I don't do it, someone else will.
Oh yeah.
But do you want them doing it when you know you could do a better job? But then at the same time, do you want to do it when you know you do a better job, but the patient still parades this mess that you had to work with and doesn't give context or backstory to why it's not such a great,
You're going to remember who did their last surgery.
Yeah.
Right.
Yeah. You're always a surgeon, even if they've had like 5 before you. So it's a conundrum that a lot of doctors get into, and sometimes it comes to bite them in the ass. It really does. I've seen it happen. It's not something that I wish upon any doctor. And I just encourage, look, I mean, if a patient comes in and they have that type of outlook, just say, look, just go watch Joe Tillman's hair transplant class on YouTube. Come back when you've gone through all the classes, you've called the show, you've watched a few times, and then we can talk. You'll understand then. That's the best thing to do. All right, so what we got in the chat room, while I'm looking at questions, we're looking for calls at 1-833-563-4247. Phone number is in the bottom corner of the screen in front of Dr. Nusbaum. We'll be on for just a little bit longer. We'll answer a couple more questions of the chat before we let him go. Let's see. Ralph asks, is laser treatment good to remove bad grafts? Have you seen good results from it? Good question.
It's always an option that we like to talk about. I don't know how well I've seen it work. The problem is a lot of times if you're trying to get a large area of grafts out, I suppose it is an option.
Yeah.
But if you're trying to just pinpoint, a couple doubles here, triples there, I don't think the lasers are small enough to really be able to target this one and target, I think you'd really have to kind of wipe out the area. The other thing is it doesn't always work in one session, so you're going to have to be going multiple times. And a lot of times what happens is it doesn't completely get rid of it. The hair is just, little by little, it just grows a little bit thinner and they're still kind of there. So yeah. I still think, some people used to, what is it called where you zap it? I forget. I'm not
electrolysis.
Electrolysis, laser therapy. I still think the gold standard is, actual graft removal.
Right.
I know some of my colleagues have actually taken a piece of skin out, and which I think is a little aggressive, and repaired the whole area. But I've seen that.
They've actually done a skin graft.
Yeah, cut the whole recession out and then put some transplants into whatever little scar was left there.
Right.
Yeah, but nowadays I think with the modern, sizes of FUE punches and the great tools that we have, I think just, a normal 0.9 millimeter punch, that was going to be the best way to go.
Right.
It's difficult. It's not fun to pull those grafts out. They're stuck, they're scarred, they're jade, they're all, the angles are all, so it's not a fun thing to do. And a lot of people will ask, can I reuse those grafts? I think about 50% of them will, you can salvage. And usually I try to put them somewhere that, just to put them in somewhere, but you're not going to really count on them. The people have to come back for a definitive second procedure. I usually will make them wait 6 to 8 weeks.
Yeah, that's a good approach. And what's your observation with actual physical removal via FUE of grafts as far as the recurrence of growth in those spots? In other words, are you always getting the graft?
Yeah, no, because. A lot of there's a couple things going on. If multi-hair grafts were put in, you're trying your best to use the smallest punch possible because it's their foreheads. You're not trying to put big holes. So there's always this happy medium of, I want to use the smallest punch possible, but I got to try to get the graft out. A lot of times if it's a 3, you may get 2 out of the 3 and 1 may come back. So it's very important to counsel patients when they're doing removals. They're probably going to want to come back to do a second session and just clean up whatever stragglers are there. The other thing that I have tried to do is something Dr. Paul Rose taught me, just to try to sort of with the hyfurcator, the little electrosurgical device, once we remove it, to just zap in the area for a couple seconds to maybe try and sort of a form of electrolysis, get rid of whatever little bulb was left behind, which I do try to do in some patients as well.
Right.
But it is very common to have to come back, even though when you're done with the first session, everything looks like nothing's there, you're probably going to have a couple of those come back.
Yeah.
So most people have to be prepared. And usually that's something that you just tell the patient, look, I'm not going to charge you for whatever grows back. Just come back and let me clean it up and do it for you. But you just have to counsel them that they're probably going to be back to do that.
And that just goes back to the thing I keep telling patients is you can never expect a single pass result with this type of extraction or repair because of what you're talking about earlier, where you got grafts that because you're using a smaller punch, sometimes you got the grafts are kind of
and they're turned
going
and they're
off
stuck.
in different directions, and you got transection, and maybe you got a hair that's going to come back. If it's a 3 hair, God forbid, and you can only get 2 of them, and one of them comes back, and all these challenges. It's never as easy as the guys on Reddit or on TikTok make it seem. It's usually a second pass of some sort, whether it be minor or major. So I'm glad you addressed that because I don't think that's talked about enough. And it's good. It's good to hear your take on it. So we're going to do one more question in the chat before we wrap this up. Or if we get a phone call, it's toll-free 1-833-563-4247. Phone number is down in the corner of the screen. But the question is, and this is an interesting one. Oh, hang on. Got a phone call. Right on. Okay, you're on the main event with Dr. Aron Nusbaum. What's your name? Where are you calling from?
Hello, Joe. This is Gypsy from Los Angeles.
Hello, Gypsy. How you doing?
I'm doing all right. I think I'm catching the end of it, but I just got out of a few meetings, and I'm like, I got to catch this.
Okay, well, you made it. What kind of questions do you have for Dr. Nusbaum?
Well, I have a couple of questions. Hopefully, they're quick. Now, the first one is in regards to the temple points. Now, what I've heard I've heard mixed statements about it, that the best hair is usually from the bottom, like the nape area. But I wanted to know his opinion or his take on that, because as I know, on the nape area, you can eventually go to traction alopecia or senile alopecia. So what's his take on that?
Okay, so I think the most important thing when talking about temple points is you need to use the finest caliber hairs that are available. Now, if you're doing a strip procedure in somebody, you're not going to do your strip in the nape area. You're going to use those supraauricular hairs. So on the sides, those are going to be a lot finer in caliber than in the mid-occiput. So that's the first thing to say. If you're doing FUE, I sometimes will go a little bit under the sort of occipital prominence, as we call it, but all the way down at the bottom in the nape, I do agree that that's an area that's sort of that whole safe zone discussion that, I do think that the safe zone can be sort of expanded a little bit to some of the traditional teachings of that. But I try to not go all the way down to that nape where you just have a few areas on the neck. I think more importantly, obviously caliber is important, but even more important for temple points is the angle that the hairs are being put in. So it has to match what the patient has here or here. The other challenge that I think some people don't even think about is that patient going to try and buzz his hair really, really short, or is he going to leave some length to it? I think the temple points are a little bit more forgiving if people, if they're trying to do a number 1 or a 0 fade, I think it's going to be very, very difficult to match the density, I would say, behind that, like here to this, regardless of whatever hair you choose. So my answer to you is, I think, yes, traditionally you can use, nape hair, you can use preauricular hair right over here, but I think the best thing that you can do is look for the finest caliber hair that's within the safe donor area and make sure that those grafts, there's mostly single hairs and that they're implanted at very flat or acute angles to the skin.
Okay, that makes sense. Now, my second question related to that is, how do you feel about body hair, using it for that purpose? And I'm talking more specifically at the arm hair. for me, for my specific case, I noted that my arm hair is very fine, close to what you would find on the temple points. How do you feel about that?
I personally have not found a case that I have had to do that. Even with patients that have pretty coarse hair, I would prefer, I think, to use some nape hair or preauricular hair than I would arm hair. But I know that it is something that some of my colleagues that are using. Anytime you're using body hair, you have to realize that it's more difficult to extract. The growth and, anagen, telogen, catagen phases are completely different than scalp hair. So those are all other factors that you need to sort of consider before doing that. Like I said, I think that on the actual scalp, you should be able to find hairs that, if they are placed correctly somewhere on the scalp, you should be able to find hairs that can be used for the temporal recessions in most patients.
I see. Okay. And next question, related to body hair. So, as I understand that if you are going to go that route, and if you're going to use something like beard hair or chest hair, that's usually best to use it as a filler, especially on the mid-scalp, correct?
Or the crown.
Not like on the crown.
Well, I don't have a problem with it. I don't mind using it in the mid-scalp or the crown. I do agree with you that it should be used as a filler, not in and of its own. But I think the area that you absolutely do not want to really use it in terms of beard or chest hair is in the front or in the hairline, really. I think you could put some beard hair mixed in the tuft in somebody if they were really light and they needed it. But in general, my kind of take on body hair, I know it's becoming standard of practice for many patients, especially for more advanced type of hair loss, and they're doing it at the same time as the scalp. I personally tell patients, look, let's exhaust your scalp hair. Even if it's through 2 or 3 sessions, let's get all the scalp hair out that we need. And then once that's done, we can always supplement it with body hair. I think beard hair grows a little bit better than chest hair, in my opinion. I think I've had beautiful results. Actually, one that I came today that was 1,000 grafts from his chest. And he actually looks great. He was a previous plug patient from my father, and he had a couple strips, and he just needed some fill, and I used chest hair, and it actually just in a very conservative frontal forelock, and it turned out really, really well, kind of to my surprise. But generally speaking, I think it should be a last resort. I don't really like to do it at the same time as the regular scalp harvesting. I think you're running into limits of anesthesia, the more different areas that you have to harvest. And I absolutely would not use it in the hairline or the front. But I do believe that in the mid-scalp or the crown, it can be used as long as there's some scalp hair around it.
Okay, that sounds good. Well, no, I mean, I'm thinking long term. If in the future there's that option, not necessarily as a primary source, but
right.
Well, it's there. I have it. It's available. So why not? Right.
Right.
So 2 more quick questions. So
Sure.
I had a consultation previously. I was given an estimate anywhere from I would say 4,300 to 5,000 grafts. By the same clinic, the 43 was done via a email, that kind of stuff, photos, and the 5,000 was actually given to me in person once the doctor saw me. For something like that, I was categorized as a 4V. As I told Joe before, I think I'm more closer to a 5. But they said, we can get this done in 2 sessions, 1 day apart each. That seems a little bit much, in my opinion, but I know this clinic does this constantly. What is your take on something like that?
I mean, I'll let Joe elaborate a little bit, but for me, I think the numbers are a little too big for my taste, personally. That's just my personal opinion. I think that you should, I don't like to do procedures upwards of 3,000 grafts. I think that's about my top number that I am comfortable doing. I think that's about the top number that, number one, I think a patient can tolerate in a day. I think that's about the top number that you can properly anesthetize a patient without exceeding anesthetic toxicity limits, which I think is the biggest risk of doing a hair transplant. And frankly, you know, to do large sessions, especially in my clinic where not everybody shaves, you know, I don't know how many people want to be in your office more than 8 to 10 hours in a day. And what I'll tell you is coming back the second day to do it after you've been there for 8 to 10 hours the first day, I cannot imagine re-anesthetizing any of my one-day post-op patients in the same area. The last thing, now, if they're separating it up and let's say they're saying I'm going to take 3,000 from your scalp and then I'm going to get a little bit of beard and a little bit of chest, fine. But I don't understand how they're going to go back through, what are they going to take 2,500 grafts from one half of your head and then take another 2,500 grafts from the other half? I just don't understand. I guess that's what they're going to kind of do. And I would say you're going to run the risk of over-harvesting the patient. So, well, I don't think it's ever good to tap anybody out in one shot.
Yeah, I think that
unless they're chopping.
What Gypsy ran into or what he's talking about is some patients or some clinics will actually, if they're doing a bigger surgery, they will take from different areas of the donor. They'll take you know whatever from one half and then come in the next day they'll take more from the other half, and it's an approach I understand. It I've seen it done even with smaller sessions when the goal is to have as much of a distribution spread for the extractions as possible, and you know sometimes they'll take it slower than other clinics, and they will do like 2,000 one day and then maybe 1,500 the next day, and spreading it out as much as possible. I think that you know. The issue between graft numbers, what any clinic will do, I think it has to do a lot with the clinic culture. There are clinics that do take a lot of grafts, and I've been on record as saying that I'm not a fan of it. Although if the clinic is getting consistently good results, then I can't argue with it. That's just my approach on it. And I come from a clinic where we were doing 5,000, 6,000, blowing people away with these huge numbers, and I feel like back then a problem developed where it was almost like the pressure was on to do bigger and better, and that was the wrong way to look at things. It was the wrong way to let that success influence the next patient or the approach to the next patient. So. The bottom line is different clinics have different approaches. If you have questions about it, just look at their respective portfolios and determine for yourself if, well, it looks like they do this on a fairly regular basis. It's not a one-off. You can feel better about it.
No, I get it. I mean, this clinic does do that, and we can talk about that later. But they do this consistently, and the results are pretty good. And
yeah.
So, but okay. But last question, and I'll get off. I just wanted to know the doctor's thoughts on the hot topic right now, which is oral minoxidil, and then I'll listen to the rest off the call. So.
All right, that's fine. Thanks for calling.
Okay. Thank you.
Yeah, we covered this already, but just do a quick summary of your thoughts on that.
Yeah, so oral minoxidil, I think it's a great treatment. That increases compliance as compared to topical versions of the same medication. I think my opinion in my patients, as well as the scientific studies that I've seen, at the doses that I am comfortable giving, where people will not have cardiac side effects, I do not believe that it is more effective than a topically applied version when done twice a day as it is prescribed. At higher doses, which I personally am not comfortable giving, it may have a superior effect to topical minoxidil, but if anybody is just going to say that they're not going to be able to be compliant with twice a day topical minoxidil, I think oral minoxidil is an option as long as that patient doesn't have any cardiac history. And I think that every patient needs to be explained, and I have them sign a consent form that it's an off-label drug. It's not FDA approved for hair loss. It's FDA approved for blood pressure. These are all the side effects that arose obviously at much higher doses, but you have to be aware of all these things.
Well said. Well said. That I like the fact that you're very thorough with your I don't want to call them warnings, but your disclosures and your education for the patient regarding anything that you do. That's really commendable. Let's see. There's one last question I wanted to slip in here from someone in the chat room.
Sure.
I'm going to disconnect the phones because we won't be taking any more calls. The question is from Scrubbity, and he says, I need help with my condition as I am experiencing an excess of sebum and hair loss. Any opinion on that from the dermatologist in the house?
Yes. So the bottom line is I have, once again, without examining you, I'm not giving you a diagnosis, but assuming you do have excessive oil production and you just have bad seborrheic dermatitis, that absolutely can contribute to hair loss. It's a form of inflammation in your scalp, and certainly can cause it, and I've seen it. So my advice would be, you should see a board-certified dermatologist. I do not think that they have to be a hair transplant doctor. They certainly can be, but I think that run-of-the-mill, excessive sebum production, scale in your scalp, hair shedding, that is something that a board-certified dermatologist should be able to treat with a combination of some topical shampoos or some topical lotions or serums to apply to the scalp to get all the inflammation and the sebum to calm down. That should at least temporarily help your hair loss. And then you have to see, do you have underlying androgenetic alopecia or not, with which you would have to treat sort of with the standard anti-hair loss therapies that we speak about. So there's ketoconazole shampoo, which is prescription. There's topical steroids that are used. Some people use, and I mean, this is getting a little bit off topic, if it was on your face, not only on your scalp, some people use very low dose Accutane for excessive sebum production. In and of itself, that can cause hair loss, so be careful of that. But this is a condition that I would see. Don't rush to just a hair transplant doctor. That's something that a dermatologist who has extensive training in hair and scalp disorders should be able to help you with.
That last medication, the
Accutane.
Accutane. Boy, I used to call that the devil drug. That thing. I know clinics that say that if you've taken it
6 months,
6 months, they still won't accept you. Got to get it a solid.
We're one
year.
of them.
Yeah, that's a tough one. Real quick before we wrap this up, what are you seeing with the pricing on dutasteride? Are you seeing an increase in dutasteride?
Oh my God! I just got a phone call of that the other day, and I take it myself, so I had a heart attack. Somebody with a coupon from GoodRx, it was like $900, I think.
What in the actual F is happening?
I don't know. But I take it, and they offered me the generic version, and I said no. So, maybe for me, my hair, and you too, Joe, our hair is quite important to us. So
yes.
I'm not changing anything, but it's insane. I don't know what the story with it is, if they're making it less. I know that I've had some patients ask me for a prescription, and they've sent it to a Canadian pharmacy where they've been able to get it. It says it's brand, GlaxoSmithKline. I don't know whether it is or it isn't, but that is an avenue that I've had some patients, actually my brother, find it like that. But I saw the CVS wanted $2,000 for 3 months supply, and I was able to get somebody a coupon on GoodRx, and it was like $900 and something. And he said, okay, I guess it's half, I'll do it. So $300 a month.
Oh my God.
Yeah.
Yeah,
and we don't know if the generic is this. I don't know. That's that's a whole other topic I've talked about ad nauseum. So, all right, well, that's a great way to wrap things up, I guess. I'd like to thank Dr. Aron Nusbaum for joining us here on the Main Event, Monday's episode, June 26th, and it turned out to be a good show. I'm glad we got some calls, but the great thing is, we got a really active support group in the chat room. And when I say support group, I mean the people that come back day in and day out to watch the show, but also to interact with each other, answering each other's questions. Because I can't see, like when I'm talking, I can't see what's going on the whole time. So these guys kind of pick up the slack and they're answering each other's questions. And I think it's nice, a nice little community that's developing around this show. And so, yeah, like I said, click the like button. Sorry, if you thought this was a helpful and useful
live stream with Dr. Aron Nusbaum. And of course, subscribe if you haven't subscribed, and ring the bell for all notifications. I'm going to be back tomorrow at 3 p.m. Pacific, 6 p.m. Eastern, and 10 p.m. Greenwich Mean Time, most likely, to take your calls and talk about hair loss and hair restoration. Until then, everyone, thanks for watching, and we'll see you soon. Bye-bye.